Hello everyone, my name is Mitchell Burton. I'm currently a fourth year student at the University of Newcastle studying nuclear medicine. So my presentation today is going to be a look at the role of technetium-99 heat damage red blood cell imaging in pancreatic gallium-68 avid lesions, in particular a case study. I think it's important to look at, why is this case study any different or any more important or worth talking about when we compare it to the thousands that you will probably do every year and the hundreds that I've seen on placement. And for me, it personally lies in the world of evidence-based practice. And I think everyone listening would have experienced the diagnosis of cancer within the family at some stage and the impact that this can have on an individual. Now, in terms of evidence-based practice, this is a look at how applying all the evidence that exists to an individual case can greatly improve the patient's outcome. It can reduce the stress involved with the diagnosis of a cancer. It can avoid the need for unnecessary steps in patient management because they're not actually suffering from a disease that they were said to be. And the main reason why this stands out is, for me personally, is because this is an example where I think as technologists and as a progressing technologist, it can often be easy to forget that every person that we scan, every person that we nearly talk to in the department is experiencing some level of anxiety and stress related to being there. And their quality of life can often ride on that diagnosis from that scan that we do. So providing the proper management in order to get the correct diagnosis not only is good evidence-based practice and clinical management, but from a personal perspective, it can greatly improve the quality of life for the patient. So our patient today is a 7-year-old male who initially presented to the emergency department with the acute onset of umbilical pain. Now, because of this, he was then sent for a CT to assess for any reason the patient may be experiencing this abdominal pain. And one thing that was found was a pancreatic tail lesion. Now, they wanted to then assess the functional status of this. So a PET gallium-68 scan was performed, and it was found that it was highly avid for dotatate. Now, other historical issues that the patient has had, there's known hepatic hemangioma, there's multiple arterial enhancing hepatic lesions. Now, there are cerebral issues related to vascular problems that the patient has had and ultimately led to a pontine stroke. Gallstones are present, and previous surgeries of the appendix and prostate have also been undertaken. So if we have a quick look at our previous imaging and kind of touch back on what we've already elaborated on within the patient history, we can see that the initial CT here noticed an incidental pancreatic tail lesion. A further CT with contrast was performed, and it was noted that there was the loss of normal pancreatic lobulation, and the hepatic lesions were also noted, and this was when the correlation with the functional status of the anatomical imaging was recommended. So we have our PET gallium-68 dotatate, which is really our key co-imaging modality in this case study, it was found that there was intense dotatate accumulation within that lesion in the pancreas. So this ultimately, as I previously stated, raised suspicion for a pancreatic neuroendocrine tumour. So some more recent imaging here. Another CT was undertaken to see if there was any progression of the disease, and it was found to be stable in size. Continuing with the lesions in the liver, they were also noted, but an FDG scan was performed, and there was very little uptake or avidity within that pancreatic tail lesion of the FDG. Some other issues here, inflammatory issues were noted within the mediastinum as well. And then some further imaging was performed, and the pancreatic lesion was also found to be stable in size. So if we have a quick look here, this is our previous imaging. On the left in figure 8, we have the arrow indicating the area of dotatate accumulation just adjacent to the spleen here. Now in B, we have our FDG image, and we can't see any accumulation of FDG similar to our dotatate there. And then likewise, the same thing is indicated on our axial slices in C and D. So the scan that is specific to this case and that we undertook was a heat damage red blood cell scan. Now, not a very common scan within nuclear medicine, but a very specific scan when performed. And the main reason it was performed in our patient was to assess for the presence of ectopic splenic tissue. Now, this has many different names, such as splenunculus or splenunculi, accessory spleen, and for the purpose of this presentation, it will be referred to as an accessory spleen. So, why would you request a heat damage red blood cell scan in the presence of a dotatate avid lesion? Well, it was showing non-avidity for FDG, so not consistent with a malignant process. And dotatate binds to somatostatin receptors because it is a somatostatin analog. Now, somatostatin receptors are also expressed on splenic tissue, so should there be splenic tissue existing elsewhere in the body besides the primary location of the spleen, you can expect that that would show and present on dotatate imaging as a neuroendocrine tumour potentially. So here we have a little bit more on the pathology of an accessory spleen. So it has multiple causes. It can be from surgery of the spleen, it can be a congenital abnormality, it can be from trauma. In the case of our patient, the exact cause is not known. And the location-wise, the splenic hilum is the most common. However, in the pancreas is second most common, which is relevant to what we're looking at today. Now, I think this has been proven to be much more common than people think it is. Now, one autopsy series extrapolated their results to estimate that 75 million individuals globally may have an intrapancreatic accessory spleen. These are most commonly noted on anatomical imaging of CT and MRI as an incidental finding, and when these are found incidentally in the case, very similar case to our patient, they're mistaken for a neuroendocrine tumour or a range of other issues. So the way you image in a heat damage red blood cell scan is actually quite simple in principle. It is collecting patient's blood, and then we labelled it to some pertechnetate using an ultra-tag red blood cell labelling kit, and then the key step is to heat it at 49.5 degrees in a dry bath for 20 minutes, agitating every 4 minutes to keep things moving, and then to bring it back down to an appropriate body temperature for injection, it's placed in ice bath for 1 minute. Now, in our patient, 710 megabecquerels of technetium-99 heat damaged red blood cells were re-injected. So, elaborating a little bit further on the pharmacokinetics of the heat damaged red blood cells. So, like all proteins, when they are exposed to heat, they denature, fragment, and in the case of red blood cells, they lose their concavity and they become a spherical shape. Now, this ultimately increases the amount that they're phagocytized by the spleen, and they become trapped or sequestrated within splenic tissue. Now, this increases for about 30 minutes to a plateau, where the then ideal target to background ratio is at 60 minutes when we like to image. And the figure here also illustrates the principle behind why we're doing the heat damaged red blood cell scan based on the pharmacokinetics. As we can see, our somatostatin receptors are present on the surface of the spleen, and then our heat damaged red blood cells are going to accumulate within the spleen. So the imaging technique that we used was 58 minutes post-injection. We acquired statics and the SPECT CT in that order. Now, the positioning supine, head out, arms down for the static, and the static is also a good opportunity to check that the splenunculus or accessory spleen is within the field of view, and any manipulation can occur for the SPECT. And then the arm is placed up for the SPECT, and as I stated, the expected area of the accessory spleen is placed approximately mid-field of view. The specific camera parameters are outlined here in table 3 and 4. Now, the real important part, what were the results? So, image A and B here clearly show, as indicated by the arrow, an area of increased heat damaged red blood cell uptake adjacent to the spleen. The axial image shows it here, the coronal image shows it here. So a better way to look at this is if we swap over and we compare it to our DOTATATE scan. So here we can see in picture A our area of increased damaged red blood cell uptake adjacent to the spleen. If we come across and we look at our DOTATATE image in B, we can quite clearly see that the locations of these match. And again, for comparison, our FDG lacking uptake. And again here for completeness, our axial slices. Now, these two locations correlate extremely well. This shows that we have a non-FDG avid, DOTATATE avid, heat damaged red blood cell avid lesion within our pancreas. Now, this is what the physicians at the time used to come to their conclusions. And the conclusions that were drawn was that the heat damaged red blood cell scan ultimately was in keeping with an accessory spleen. Now, this also rules out the diagnosis of a pancreatic neuroendocrine tumour from the gallium-68 DOTATATE scan. Now, this is the key point that I went back to in my why is this case important slide, in that this negated the need for this patient to undergo, likely, a pancreatectomy to then only reveal on biopsy that it was splenic tissue. This significantly improved this patient's outcome, which is a fantastic result in my opinion. So I'd like to thank everyone for listening to this presentation today.